Hello, good morning everybody. I'm Dr. Rohini Gupta and I'll be covering the week 5 contact session, which is the clinical session on women and HIV and perinatal HIV. I hope you have heard the two lectures which were there in the module. The first lecture is Women and HIV, Focus on Reproductive Health by Dr. Jennifer Unger. And lecture 2, Mother to Child HIV Transmission in Resource Limited Settings. Next कैसे जाते हैं? The learning objective is to describe the current global HIV epidemic in young women, to discuss the reproductive care and options, recommendation for women living with HIV across reproductive continuum, and integration. So we start with primary HIV care, including preconception care, antepartum care, intrapartum care, and postpartum care. AIDS is the biggest global killer of women of reproductive age. The WHO planned a comprehensive strategy of prevention of transmission from mother to child. That is, you do HIV testing of all pregnant women, give ARVs to mother and infant, and appropriate care and treatment for mother, child, and families. This was the PMTCT strategic vision between 2010 to 2015. Prevention of primary infection among women. The important thing is partner testing. Prevent unwanted pregnancies, promotion of family planning, availability and use of contraceptives. Despite this high transmission rate, despite such effective interventions, what are the causes? In most high-income countries, the transmission has been virtually eliminated. Children account for 10% of all new infections. 90% of NTCT HIV transmission events occur in sub-Saharan Africa. In resource-limited settings, progress to scale up the PMTCT has been slow. What are the reasons? What are the outcomes of interest? Outcomes of interest is that an HIV negative mother and an HIV positive mother on adherent ART with viral suppression and a HIV negative baby. So what are the progress? We find out whether the interventions have been effective by knowing how many number of infants were infected, number of HIV infected women getting ART, and pregnant women receiving HIV testing. It was found that these are the countries which accounted for 89% of all HIV positive pregnant women in low and middle income countries in 2011, out of which India is also included in this. And these were the priority countries which the global plan was to be implemented at. In US, 10,000 new HIV infections among US women. Majority are diagnosed during their reproductive years, that is 15 to 45 years. Perinatal transmission of HIV is achievements and myths. The basic thing is that HIV positive women can give birth to a HIV-free baby, and in US, perinatal HIV infection has been reduced to less than 2%, less than 200 cases. And how was it achieved? It was achieved by universal prenatal HIV counseling and testing, preconception care, ARV prophylaxis, scheduled cesarean section deliveries if indicated, and avoidance of breastfeeding. They said that every HIV infected infant is a sentinel event, and they would find out why this has happened and represent a missed opportunity. Every HIV infected woman is a sentinel event representing a missed opportunity, because that lady who's not detected preconceptionally. So, what is HIV care through reproductive continuum? Basically, it is these steps, that is primary HIV care, preconceptional care, antepartum care, intrapartum care, and postpartum care. Now, where do we miss out on the thing? If the missed opportunities are HIV infected woman MOSA status, doesn't receive any preconception care and gets pregnant. During pregnancy, doesn't receive any prenatal care, no HIV testing, inadequate HRV, ARV prophylaxis. According to the US guidelines, should have undergo cesarean, doesn't undergo cesarean, breastfeeds the baby, and the child gets infected despite treatment. So what are our steps of prevention in this? The first thing is that an HIV infected lady with an unknown status should be diagnosed. So primary HIV prevention for women and girls. The second step of prevention is adequate preconceptional care and family planning services. Next is accessible, affordable, welcoming prenatal care. The fourth preventive step is universal prenatal HIV testing. We have an opt-out where the pregnant lady can opt out of testing HIV. We should actually be removing that opt-out option. Providing ARV prophylaxis to all eligible babies. Utilize cesarean delivery if maternal viral load is more than 1000 copies. Avoidance of breastfeeding as per US guidelines, and a comprehensive service for mother and infant. These are US guidelines. Preconception counseling and care, basically 4 steps. Prevention of unintended pregnancies, unplanned pregnancies, maternal health prior to pregnancy, prevention of perinatal transmission, and prevention of HIV transmission to an uninfected partner while trying to conceive. These are the 4 steps of care. What are the recommendations? We must discuss childbearing intentions with all women of childbearing age on an ongoing basis. That is, every contact period we must discuss this. Then what should we discuss? We should discuss what are the contraceptive methods. Preconception counseling includes information on safer sex, condom usage, elimination of alcohol, illicit drugs, and smoking. Preconceptional counseling also includes assessment of HIV status and starting ART in this lady before she conceives. Choose an ART regimen for the infected woman of childbearing age depending on the efficacy, hepatitis B status, teratogenic effect, potential and possible adverse outcomes for the mother and fetus. But now lots of studies have been done and they found tenofovir and equivalence is not teratogenic and safe during pregnancy. Fertility desires. A lot of our patients have this fertility desire and intention and do want to have children but are very scared and they do not communicate the same questions to the healthcare workers. So what is it that between 50 to 80% of HIV positive women have a desire for children, and this is likely to be the same as in the general population, and there is an estimate large number of zero or discordant couples in US, over half of whom desire conception. So these zero discordant couples, there's a chance of giving infection to the uninfected partner. What is pregnancy by intention status? nearly half of the pregnancies are unintended, and intended are 52%. Unintended pregnancy and women with HIV. Among HIV-infected women, rates of unplanned pregnancy range from 55 to 65%. And among HIV-infected adolescent women in the US and Europe, estimates of unintended pregnancies are very high, up to 83%. So, what is the thing? The important insight we need to know about HIV positive women is that those who, of the two, there was a survey done, published in AIDS Patient Care, May 2011, which study of the 2 to 7 women who have been pregnant or those who would consider pregnancy, approximately half were never asked by their healthcare providers if they had or were considering having children. Of women who were pregnant or were thinking of becoming pregnant, 57, that is half of them, had not discussed what are the appropriate treatment options with their practitioners before pregnancy or before becoming pregnant. So each young lady, adolescent girl or a sexually active young lady who's not pregnant at present needs counseling, needs to be informed about what are the possible treatment options available, and contraception works. This is important to know. 2/3 of the US women at risk of unintended pregnancy who practice contraception consistently and correctly account for only 5% of unintended pregnancies. That means if contraception counseling is given, very few unintended or unplanned pregnancies will be there. Of course, this contraception should be a consistent and current use, so repeated counseling is required. HIV and contraception counseling. There are 3 steps. One is to know exactly which specific contraceptive is available, what is its efficacy in preventing pregnancy, and is it safe in HIV-infected women. What are the drug interactions, what are the side effects. So first we talk about oral contraceptives. So oral contraceptives are either estradiols or progesterone products. And the most important thing we must know is ethinyl estradiol activates the CYP3A4 pathway. It's a liver inducer. So what will happen? Enzyme-inducing drugs decrease circulating estradiol and progesterone. So there is a potential reducing the effect of oral contraceptive. What is antiretroviral drugs and the effect on this liver enzyme inducers? NMRTIs are inducers, protease inhibitors are inhibitors. What important is to know is that integrase strand transfer inhibitors and tenofovir, that is nucleotide reverse transcriptase inhibitors, do not have any drug interactions or with oral contraceptives. They are safe to can be given because they do not affect the CYP450 system. This is just a list of interactions of various hormonal contraceptives and ritonavir boosted protease inhibitors. You should look at this slide. All of them reduce the efficacy of oral contraceptives. Equivalence also, as I said, NMRTIs also reduce the efficacy of oral contraceptives. What is important to know is that etranacogene and rilpivirine do not require any dose adjustment of oral contraceptives, but the other what is available in our country, that is equivalence and epilepsy, does reduce the efficacy of oral contraceptives. So efficacy can be compromised by drug interactions between estrogen and certain antiretrovirals. This is NNRTIs, that is equivalence in everything, protease inhibitors. And remember, if the patient is on ART and ATT, then other medications including rifampicin, again an inducer, will reduce the efficacy of oral contraceptives. So what is the US update? Recommendations for the use of hormonal contraceptives in women at high risk for HIV infection or infected with HIV. The use of hormone contraceptives is safe for women at risk for HIV, that is USNEC category 1. And all women who use contraceptive methods should remember and be counseled that condom uses is important. It is not that you are taking oral contraceptives and you do not use condom. So condom use is very important as it will avoid protect from STIs and protect for reinfection by a different strain of HIV. What about DMPA? This is an injectable contraceptive which effect lasts for 3 months, and it is to be given every 3 months intramuscular, and it's a very effective contraceptive. So a lot of studies have been done on relation between DMP and HIV. This is what is called a forest graph. And basically, the thing is risk of hazard ratio risk. So 3 studies have shown less risk, 7 studies have shown a higher risk of getting HIV. The data, but at present, what CDC and WHO say that the data suggests that there is an association between progestin only injectable contraceptive and increased risk of HIV transmission. Whether this is a causal association is not clear and not conclusive and enough to recommend against using this very effective and otherwise safe contraceptive. So as per CDC, this is a very safe contraceptive option, but it should be an informed option where you tell them that studies are being done where some association of increased HIV transmission and increase in risk of HIV is there, but studies have not been conclusive. WHO also says the same, that there is low to moderate evidence of primary HIV acquisition even in non-infected patients. That is, there is a high risk of them getting HIV, but because there is no evidence, so it has to be, women have the right to informed decision making. Women prefer to have choice in method. Full information should be given to them about the risks, though not conclusive, and if they are still willing, they can continue, they can start taking this good injectable contraceptive. What about IUDs? IUDs are intrauterine devices, what in our country is known as copper teas. Lately, there are new hormone secreting putties or IUDs, which are called LNG IUDs. These slowly secrete progesterone into the uterus. The advantage of this is that there is 50% of the ladies after about 2-3 months of using these IUDs become amenorrheic, so they do not have their periods, hence the hemoglobin levels remain. So especially useful in anemic HIV infected patients. Also, they have not found any high risk of cervical and vaginal infections. Also, the cramping pain, which was one of the biggest side effects seen in IUDs with copper teas, is not there because of this progesterone release, which is there and reduces the cramping. This is what is medical eligibility criteria category, which is seen in CDC. So the best category is 1 or 2. 1 is there is no restriction of use of contraceptive method. And two is advantages of using the method outweigh the whatever theoretical risks are there. What should not be used is 3 and 4. So let's see what is the criteria for various. So updated CDC panel recommendations are: discuss childbearing intentions with all women of childbearing age, include information on safe sex, elimination of alcohol, illicit drugs, smoking, most important, daily multivitamin supplementation with 400 micrograms of folic acid. All HIV infected women contemplating pregnancy should be on a maximally suppressive antiretroviral regimen. When selecting or evaluating combination antiretroviral therapy for HIV infected women of childbearing age, consider effectiveness, hepatitis B status. This is no longer there. Teratogenic effect of efavirenz has been excluded. So what are the reproductive options for HIV serodiscordant couples? First is initiate ART for the HIV infected partner. This is very important. Maximum viral suppression is recommended before any pregnancy is planned. The second option is HIV infected female with uninfected male partner. The safest option is artificial insemination during the peri-ovulatory period. What has been seen is that the semen, once centrifuged and concentrated, will be able to be inseminated. An option of self-insemination during the peri-ovulatory period has shown the efficacy of shows that pregnancy in this way would be effective and the non-infected partner will not get infected. But no studies have been done on this, and the other thing is to use PrEP if you're not going to be doing a artificial insemination. Reproductive options in a HIV infected man with uninfected female. What we do is use donor sperms, or in couples in which the man is HIV infected, the use of sperm preparation techniques coupled either with insemination or IVF is proven to be highly effective in avoiding seroconversion of uninfected women and offspring. This is what the committee has said. So IVF done, there are very low chances of infection to the uninfected mother, and the baby also is unaffected. What happens if you have an HIV infected man with an uninfected female? So there was a study done where they found that 1600 inseminations of about 500 HIV uninfected women resulted in 228 pregnancies. Of these, 97% of the women after 3 months and 92% of the babies at 1 year showed no signs of HIV infection. What is PrEP for conception? This is pre-exposure prophylaxis. Pregnancy is not a contraindication for PrEP. Pre-conception and pregnancy administration of PrEP for HIV uninfected partners may offer an additional tool to reduce the risk of sexual transmission. The utility of PrEP of an uninfected partner when the infected partner is receiving ART has not been studied. Maybe it is possible if some studies are done that you may not require a PrEP if the infected partner is on ART. But no studies at present are there. So PrEP for conception is a good option. This option is not available in our country. This is what is available in US. What is the prenatal evaluation? Is the same what we do, except that in US they also do a viral load, they also do drug resistant testing, especially if the RNA load is more than 1000. Immunizations is a very important part of their prenatal evaluation in US. Antiretroviral therapy, all pregnant HIV-infected women receive a combination of ARV drug regimens regardless of CD4 count and RNA load. This is very important to reduce perinatal transmission. This is the same what we have. I just wanted to tell you what are the US Department of Health and Human Services 2016 perinatal ART guidelines, that is what is called DHSS guidelines. So the guidelines for intrapartum antiretroviral therapy. Women should continue their antepartum combination ART on schedule as much as possible, and a scheduled cesarean delivery is planned, is what is followed by there. Intravenous delivery should be administered only to women on ART whose viral load is more than 1000. Not required for women whose RNA viral load is less than 1000. A scheduled cesarean delivery at 38 weeks gestation is recommended for women who have more than 1000 viral load. So any lady on ART with a planned pregnancy having a RNA load of less than 1000 copies can have a normal delivery. What are the recent changes? The recent changes are, which should be highlighted is, which is not there in our guidelines is, IV Ziluvudine administered to an HIV infected women with RNA more than 1000, or a lady whose unknown HIV RNA comes to you for delivery. This is not required for women whose RNA load is more than 1000. So what is the intrapartum care? I already told you about cesarean. Let me talk about AROM. Minimum interventions. AROM, operative vaginal delivery, scalp monitoring, scalp blood monitoring, all these should be avoided. And no methogen if on a PI based regimen or efavirenz. We must remember this. Most of our healthcare workers forget about it, but no methogen is given if the patient is on a PI based regimen or efavirenz. What is the DHSS guidelines for HIV-2 infection? For HIV-1 and 2 infection, it should be treated as an HIV-1 mono infection, but one must use antiretroviral drugs to which HIV-2 is sensitive. What usually they use in US is 2 NRTIs and a boosted protease inhibitor or an integrase strand transfer inhibitor for all HIV-2 infected pregnant women. This is the difference between them, because they have integrase strand transfer inhibitor available, so that can be used as a first line therapy for HIV-2 infected pregnant women. Remember that NNRTIs are not active against HIV-2, it should not be used. All infants born to HIV-2 mothers should get Ziluvudine. We are also following the same ARV prophylaxis for 6 weeks. We are also following the same prophylaxis. But in US, they prefer telling the mother to have infant formula and not breastfeed for all infants of HIV-2 infected mothers. Vis-a-vis, NACO guidelines say that even in HIV-2 infected mothers, if she's had adequate ART and ARV prophylaxis, mother can continue breastfeeding. DHSS, that is US guidelines for acute or recent HIV infection. All pregnant women should be started immediately on ART, and the goal is to get good HIV RNA suppression it should be the viral load should be non-detectable. In women, they also do a genotypic resistance testing simultaneously with initiation of antiretroviral therapy, and the regimen should be actually adjusted as soon as you get the report. What is advised in an acute or recent HIV infection is a ritonavir boosted protease inhibitor based regimen with tenofovir. Should be initiated. We do not have any guidelines because we do not do viral load. We cannot actually diagnose an acute or recent infection. But these guidelines are US, and you must know these guidelines, especially for doing all your quizzes. What is the DHS's 2016 guidelines for women who present in labor with unknown HIV status? Women who present, they should be immediately tested. If the results are positive, a differentiation test needs to be done as soon as possible, whether it's HIV-1 or HIV-2. Pending the test, maternal zidovudine, IV zidovudine is given to these ladies, and baby is started on ARV prophylaxis. A combination ARV prophylaxis is given in these babies born to these mothers who come present in labor. I'll be telling you about it. It's a combination of nevirapine and zidovudine prophylaxis syrup, which is given over. Zidovudine is given twice a day for 6 weeks, and nevirapine is given 3 doses. I'll be telling you in another few slides. I'll be telling you about infant prophylaxis. But this is the difference between NACO guidelines and US guidelines. If the maternal HIV differentiation test is negative, then and the acute HIV infection has been excluded with a negative HIV RNA test, then all maternal and infant ARV drugs should be stopped. Those mothers who are positive initially and confirmation test is pending, according to the US, should not be breastfed. The baby should not be breastfed. Now, what is infant? What I was talking about, ARV prophylaxis. All exposed babies should receive ARV prophylaxis within 6 to 12 hours. It is 4 weeks neonatal zidovudine prophylaxis given twice a day. When are the indications for a combination infant ARV prophylaxis? The combination infant prophylaxis regimen is recommended in mothers who have not received any antepartum or intrapartum ARV drugs, that is, comes in labor and is diagnosed as infected, has received only ARV drugs like IV zidovudine during the delivery time, and third indication for combination infant ARV prophylaxis is has received antepartum ARV drugs but has not shown viral suppression near delivery. These are the 3 mothers who are high risk for giving HIV infection to the baby, and US guidelines say that they should have a combination. So what is the combination? The combination is 6 weeks of zidovudine and 3 doses of nevirapine given at birth, 48 hours after the first dose and 96 hours after the second dose. This was about guidelines in US. Now we talk about PPT-CT, prevention of parent-to-child transmission in resource-limited countries. This is the global epidemiology, where estimated number of children newly infected with HIV are 1.5 lakhs. There was a global plan for PMT-CT that was launched in 2011, and it had the following benchmarks of progress, that is doubling the proportion of pregnant women on ART in 21 of the 22 priority countries, the rollout of option B plus in all but one of the priority countries by 2015. Actually, 60% decline in new HIV infections among children in the priority countries. One country has not been able to achieve this. See, and 50% reduction in number of new HIV infections among women of reproductive age has not been achieved by all the 22 priority countries. So of these have been achieved, and the benchmark which has not been achieved is 50% reduction in the number of new HIV infections among women for reproductive age. What are the WHO PMTCT guidelines? That ART should be initiated in all women, pregnant and breastfeeding women living with HIV regardless of WHO clinical stage or CD4 count. What are the advantages of this option B? This is called option B. One is that it's become very simple. You do a CD4 testing, but we don't wait for the report to come and we start mothers or pregnant HIV infected mothers on ART. It also gives extended protection for the future pregnancies. Prevention benefit against STI, sexual transmission, especially occurs in HIV discordant couples. That is, an infected pregnant mother will, if put on ART, there's reduced risk of transmitting it to the negative partner. It also benefits to the woman's health. She has less OI infections. She has a better health. And once ART is started, it has to be lifelong. So this is a simple message which is passed to the community that all pregnant women started on ART taken for lifelong. For the community, it improves the individual health outcomes, it prevents mother-to-child transmission, and also reduction in infection in the uninfected sexual partner. What are the WHO feeding guidelines? It says exclusive breastfeeding during first 6 months. This is a change in emphasis or difference from what is being advised in US. Formula milk is only given where these criteria, 6 criteria are met. I'll be discussing infant feeding in the later slides. What are the challenges in this implementation of option B? One is challenge of lifelong treatment, adherence, compliance, retention and care. And mothers usually take their medicine throughout their pregnancy, but during breastfeeding period sometimes take, sometimes stop taking. One of the questions has been asked is, IV zidovudine is given as a single dose during pregnancy, is not to be continued after delivery. It is a single dose of IV zidovudine is given, and the dose of IV zidovudine I have not mentioned here, but it is given in the guidelines. It will be good if you could go through the guidelines and have a look at them. Loss during transition postpartum, that is the integration of PMTCT and CCC is not well integrated. We need to also track these pregnant women or breastfeeding women. Early infant diagnosis is very low in 35% in the 21 countries where the global plan was to be implemented. What are the implementation insights we received? If you want to reduce this 1.3 million HIV infections have been averted by this new option B plan. And yes, I agree. This is another question. IV zidovudine is not to be given in India. It is not NACO guidelines. I repeat, IV zidovudine is only advised by US, and we are doing it because I'm speaking about it is because we are doing an online course from US. So their guidelines are also to be learned to be able to do the quiz. I repeat, IV zidovudine is not to be used in India. What are the important steps which will help us achieve the good results of MTCT, PMTCT is we must nudge out this opt-out testing. We must have point of care service. Peer involvement is very important. Correct messages need to be given and staff need to be accountable. This is about India. Now let's talk about what is happening in India. What is the HIV prevalence amongst pregnant women? It's marked by this maroon color. Please look at this. 6 high prevalence states. Mostly the south states are there, but remember, if you look at it properly, you will see that this maroon color is there in all the states, small pockets in all the states. So as such, HIV prevalence amongst pregnant women is there in all the states of India. This is just a list of how the PBTCT services evolved in India. And what we need to look at is the 2014 January guidelines that all HIV positive pregnant women, regardless of CD4 count, WHO's clinical staging, option B plus, has to be adopted. So what is our vision and our national strategic plan? What is the vision, goal and objectives? So vision is that we have a vision of women and children alive and free from HIV. Our goal is to work towards elimination of pediatric HIV, improve maternal and newborn and child health and survival in the context of HIV infection. And how will we achieve this goal? By these objectives. To detect more than 80% HIV infected pregnant women in India, to provide access to comprehensive PBTCT services to more than 90% of the detected pregnant women, to ensure more than 94% compliance with ART in HIV infected pregnant and breastfeeding women, to provide access to early infant diagnosis to more than 90% of HIV exposed infants, a very big challenge. And fifth is to ensure access to antiretroviral drug prophylaxis, or if the baby is diagnosed infected, to 100% of HIV exposed infants. The meaning of this is that all babies born to HIV infected mothers need to be given either ARV or if diagnosed infected, ARV prophylaxis to be stopped and ARV to be started. ARV prophylaxis given in India, I'll be speaking. What I spoke till now was US guidelines. What I'm speaking now is NACO guidelines. So please follow the NACO guidelines. US guidelines is just for information. The routes of HIV transmission, this PBTCT has reduced. In 2010-2011 it was 5%. Now it is reduced to 3%, which is a very good achievement, and we have achieved this because of our option B implementation. The hurdle which we are finding in our country is this HIV testing in pregnant women. But even this has shown a good response. The testing number of HIV pregnant women tested for HIV have increased. Vis-a-vis, the positivity rate has come down, so this is a good sign. But still, there is a gap. In India, 28 million pregnant women are there. Of this, 41% have been tested, and more than half of them have not been tested. So what is the key challenge we need to undergo, which we need to face, is to enhance detection of HIV positive pregnant women in low HIV prevalence states. This gap needs to be reduced, the red color, of those who are not tested. And this, we need a lot of private practitioners contribution. So this is about private sector contribution in estimated HIV positive pregnant women. The estimated HIV positive pregnant women was estimated as 35,255. Private sector accounted for 1/3. Okay, and 67% for public sector. So 11 states and 2 union territories contributed for 89% of those estimated HIV positive in private sector, and these occurred in Maharashtra, Karnataka, Andhra Pradesh, Tamil Nadu, Gujarat, West Bengal, Rajasthan, Kerala, Jharkhand, Orissa, Telangana, Puducherry and Delhi. This is what is important to see, and this is what is shown here, that these 11 states and 2 union territories contribute for 89% of the HIV infected in the private sector. And that is why we need to have the private maternity homes testing HIV and reporting to NADA. The estimated pregnant women needing PPTCT, the 7 states, that is these 7 states are contributing for more than 50%, more than half the number of pregnant women who need PPTCT services. Now, MTCT transmission occurs during 3 phases: during pregnancy, during labor and delivery, and through breast milk. What is the major factor that increases the risk of MTCT? 1. Amount of HIV viral load in the mother's blood. We do not monitor this viral load, so we monitor it by the CD4 count. The only way to prevent mother transmitting HIV to the baby is by giving light from ART therapy, and mother should be adherent with that therapy. So this is what is the risk of the baby getting infection if the mother is infected in absence of any intervention. That is, the mother doesn't take any preventive action. So the overall risk with breastfeeding for 2 years is 30 to 45%. The breakup is during pregnancy, it is 5 to 10%, during labor and delivery is 10 to 15%, during breastfeeding is 5 to 20%. Overall, without breastfeeding is 15 to 25%, and overall with breastfeeding 20 to 35%. All these are if no intervention is done. What is the risk? In a simpler way to explain to parents is that each baby born to an HIV positive mother doesn't get infection. If 100 mothers were there, 5 of these 100 babies would be infected during pregnancy, 15 of these would get infected during delivery, and 10 of these would get infected during breastfeeding for 6 months. So this is a simple way of explaining these percentages. That is, if no intervention is taken or nothing is done in these HIV positive 100 mothers and they deliver 100 babies, the important thing to note is that this total comes to 30. That 70 babies will not get infected. Of the 30 babies which have a risk of getting infected, 5 are during pregnancy, 15 during delivery, and 10 during breastfeeding. So the highest risk is during labor and delivery. So these are the reasons why we insist that it should be an institutional delivery so that the baby can be given ARV prophylaxis, because the highest risk is during delivery. ARV prophylaxis given to the baby is very important, and this is the reason. The reason of giving it for 6 weeks is to cover this risk which is occurred during delivery. So what is the essential package in India of PPT-CT? One is that routine offer of HIV counseling and testing with opt-out option is there for all pregnant women coming. It should be implemented even in the private sector. Ensure involvement of the husband and family members. If it's diagnosed HIV infected, the pregnant mother must be started on lifelong ART, and this ART should be adherent, should continue during the breastfeeding period and lifelong. Promote institutional deliveries. The reason I told you was the highest risk is during delivery. Provision for care of STIs, RTIs and other opportunistic infections. Nutritional counseling and psychological support to all positive pregnant women. ARV prophylaxis to the infants. This is very important because this will reduce the whatever risk of exposure during delivery is there will be covered by the ARV prophylaxis to the baby. We follow up all babies born to HIV infected mothers for 18 months. The main aim of following up these babies is to detect HIV infection at the earliest. If diagnosed infected, to be started on ART. So our basic goal of follow-up of HIV exposed infants is initially to give ARV prophylaxis and thereafter to do the regular EID diagnosis by DBS to detect infection. If found to be HIV infected, baby needs to be put on ART. Along with this, cotrimoxazole prophylaxis is given to all babies till HIV infection is not excluded. Now, what is the continuum of care by NACO for HIV infected pregnant and breastfeeding women? We saw what was in the US guidelines. Now we will be speaking about our guidelines, Indian guidelines. So, antenatal PPTCT services, all HIV infected mothers need to be initiated on ART. They should continue ART during intranatal, during the delivery, which is called PPTCT services. Postnatally also PPTCT services need to be continued, and counseling in all these phases is very important. Each contact with a pregnant mother needs reinforced counseling, and encourage institutional deliveries, because only then will you be able to start ARV prophylaxis immediately to the baby born to this mother. Link this pregnant, newly diagnosed HIV infected mother to the ART center where she is investigated and ART is started. So all three of them have to be linked. If the mother is diagnosed during breastfeeding, again she is counseled and she is told to, she is linked with the ART services, and all these babies born to these mothers need to be linked to the EID program, and if diagnosed infected, to be started on ART. What are the four-pronged strategies we need to do? So our first strategy is prevention of primary infection of HIV. So how do we do this? This is HIV negative general population. So increase awareness of HIV, sexual health, condom use, contraceptive use in sexually active women. Prong 2 is prevent unintended pregnancies. That is, if you have an HIV pregnant lady, sexually active young person in your ART clinic, please counsel about family planning. Very few of us counsel about family planning, but it is more important so that she can have a planned pregnancy and avoid any unintended pregnancies. Third prong of prevention is in a HIV positive pregnant mother. The steps have already been explained. Start on ART, ensure institutional delivery, ARV prophylaxis in the baby, and breastfeeding. The postnatal care, prong 4 is care and support and treatment of both the HIV positive mother and its baby. And what is the steps in this is that the baby is followed up for 18 months. It's integrated into the EID program where early HIV testing, the DDS testing is done to detect HIV infection early. Any baby detected with HIV infection is to be started on ERT. There is a question about why methogen is not to be given. See, injection methogen is not to be given if the mother is on efavirenz and PI based regimen because of drug interactions. If the patient is not on either of these medicines, mother can be given methogen. Interventions during pregnancies, primary prevention of HIV, provide HIV information to all pregnant women. Antenatal visits are opportunities for getting HIV testing done. Planned pregnancies, anybody diagnosed infected needs to be started on ERT, and safe delivery practices. Now, this is very important. Counseling of patients who are HIV infected on ART adherence and healthy living practices. Precautions to be taken by pregnant and breastfeeding mothers to reduce HIV transmission to baby are regular condom usage to avoid HIV reinfection and STIs, adherence to ART during pregnancy, labor and entire breastfeeding period, antenatal counseling for feeding options by parents, reinforce counseling postnatally, care of nipples and breast, recommended nutritional requirement for HIV infected pregnant or lactating mothers. The current recommendation is increase in energy intake for HIV infected pregnant and lactating women is the same as you would advise to a non-pregnant, non-breastfeeding HIV infected woman, that is 10% more than an uninfected mother during a symptomatic phase, and if the patient is symptomatic or ill, then 30% more than non-infected mothers. But nutritional counseling is aimed at eating wisely during pregnancy and breastfeeding, which is the same for all pregnant women whether they are HIV infected or not. Interventions during labor and delivery, minimize vaginal examinations, avoid prolonged labor, consider oxytocin to shorten labor, avoid premature rupture of membranes, avoid use of partograms to measure labor, avoid artificial rupture of membranes, do not use suction unless absolutely necessary, and early cord clamping after it stops pulsating and after giving oxytocin to the mother. Labor interventions during continued is avoid unnecessary trauma during delivery, avoid non-invasive, avoid invasive fetal monitoring, that is scalp, blood pH monitors, use non-invasive fetal monitoring, avoid routine episiotomies and tears, minimize the use of forceps or vacuum deliveries. For all infants, when the head is delivered, wipe infant's face with gauze or cloth. After baby is completely delivered, thoroughly wipe dry with a towel and transfer to the mother. And this is probably one indication of giving a bath to the baby, where you wash off all the blood which is contaminated with HIV. Considerations in mode of delivery in India, normal delivery is recommended unless the lady has obstetric reasons for cesarean section like fetal distress or obstructed labor. So all should be advised vaginal deliveries. This is similar to what is advised in non-HIV infected mothers. It has seen that an adherent ART taken by the mother, use of ART will reduce the risk of transmission of HIV to the baby, and the risk of cesarean section is more to the mother. So after a lot of studies, it was decided that in India we will be advising vaginal deliveries unless indicated because of fetal distress or obstructive labor or cesarean section is done. What are the interventions during infancy? We must clinically follow up all these babies for any signs and symptoms of HIV infection. All HIV exposed infants should receive cotrimoxazole prophylaxis at 6 weeks of age. Follow standard immunization schedule. You have routine well baby visits, early infant diagnosis, and the final diagnosis at 18 months for HIV antibody test. This 18 months test is not final if the mother is breastfeeding. So the last test would be 6 weeks after stopping breastfeeding. So if the mother is breastfeeding beyond 2 years, then the last testing will be done 6 weeks after breast milk is stopped. What is the ARV for mother and ART for the mother and ARV prophylaxis for the infant? So lifelong ART to mother for her own health and also for PPTCT. How does PPT work? Again, I'm just repeating it so that I'll reinforce that, and this is how you reinforce in a pregnant lady. You say you must be adherent to your ART because that will reduce the maternal viral load, and also if this antivirals which mother is taking will pass will pass into the fetus through placenta and prevent, if any transmitted viruses are there, from replicating. So it does a dual job. It reduces the viral load in the mother and also loads the fetus with antiretrovirals which prevent any transmitted viruses from replicating. And ARV prophylaxis in the infant, what we are using is 6 weeks nevirapine syrup up to 6 weeks. Thereafter, the extended nevirapine prophylaxis I'll be speaking later. So after all these ARV interventions which we have given, that is ART in the mother and institutional deliveries of the pregnant lady, followed by ARV prophylaxis in the baby, what has been the difference in the ARV interventions? If nothing was done and the mother was breastfeeding, the transmission rate would be 30 to 45%. But if you are giving ART to the mother and ARV prophylaxis to the baby, and the baby is breastfeeding, the risk is 2%. That is important to see. And if the mother is not breastfeeding, the risk is 1%. So with all these ARV interventions like ART in the mother, institutional deliveries, ARV prophylaxis to the baby, breastfeeding of the baby, the risk has been reduced to 2%. That is, only out of 100 babies, only 2 will get infected. This message needs to be conveyed to the parents. So this is just a gist of how we evaluate a HIV infected pregnant woman who comes. If she is detected during antenatal care, we link her to the ART center. In the ART center, we take a sample for CD4 testing, but we initiate her on ART and counsel her for an institutional delivery. If the lady is already registered in the ART center and is in pre-ART care, we take a CD4 sample and initiate her on ART. If the lady is on ART, we do a repeat CD4 test as per guidelines. You don't need to do a repeat test immediately after she is pregnant. but she needs counseling about adherence of her ART, use of condoms for avoiding exposure to reinfections and STIs, and continue current ART regimens. If needed, if there are some problems, it may be changed. But most ART drugs which we are prescribing do not have any toxicity and they should be continued. Avoid changing any regimen during pregnancy. Women who come directly in labor, immediately a screening test is done in the labor room. A confirmatory test is done as soon as possible. A CD4 count is done. Baby is initiated on ARV prophylaxis and mother is initiated on ART as soon as possible. Now there's a breastfeeding mother who comes and she's detected HIV infected because of some reasons. She's ill or she's got tuberculosis, and what we do here is immediately start her on ART. Take a CD4 sample but do not wait for the CD4. Continue, tell her to continue breastfeeding, start her on ART and do EID in the baby. That is, this baby who is breastfeeding also needs to be tested, integrated into the early infant diagnosis. What are the NACO guidelines? What ART to start? We have lifelong ART, tenofovir, lamivudine, efavirenz for all HIV positive, pregnant and breastfeeding women regardless of clinical stage and CD4 count. Pregnant and breastfeeding women not already receiving ART, we must start the same. There is no indication for abortion, termination of pregnancy in women exposed to efavirenz in the first trimester of pregnancy, as recent studies have shown that there is no increase in the incidence of neural tube defects in these babies. Pregnant and breastfeeding women not already receiving ART is TLE once a day taken at bedtime. Women presenting directly in labor, screen for HIV. The labor room nurse will offer bedside counseling and HIV screening test. If women consent, screen using the whole blood finger prick test in the labor room. If detected positive, medical officer will initiate on TLE, which is available in the labor room, and ensure immediate linkage to the ART center. Labor room nurse informs the ICTC counselor and lab technician for further confirmation of HIV test as per guidelines. Pregnant women presenting in active labor, we have no ART, we must initiate ART and continue ART and give 6 weeks nevirapine prophylaxis in the infant. In these cases, if the mother is planning to breastfeed the baby, then we increase the prophylaxis duration to 12 weeks. But if the mother is planning to do replacement feeding, then 6 weeks of nevirapine is good enough for that baby. ART has to be lifelong. What are the ART prophylaxis according to NACO guidelines? Nevirapine is given as a single dose, and these are the doses of syrup nevirapine. All of us are using this syrup nevirapine prophylaxis. All babies born to HIV infected mothers are given 6 weeks of nevirapine prophylaxis once a day. At 6 weeks, we find out whether the mother is breastfeeding or not. If the mother is breastfeeding, then, and the next question we ask the mother is, when was your ART started? If her ART duration is less than 6 months at the time of delivery and she is breastfeeding, then to protect the baby, we need to extend the syrup nevirapine prophylaxis to 3 months. But what is to note is that this is done only in breastfeeding mothers, breastfeeding babies. Babies who are on replacement feeding do not require extended nevirapine prophylaxis. because after six weeks covers the perinatal transfer of risk of HIV for whatever exposure has happened during delivery. After 6 weeks of nevirapine, the extended is to look after the breastfeeding risk, as ART takes 3 months at least for viral suppression to occur. ART prophylaxis for infants born to women who do not receive any ART, that is home deliveries. So we must start nevirapine prophylaxis at the first contact with the health services. Daily infant nevirapine prophylaxis can be started even if more than 72 hours have passed since birth. Daily infant nevirapine prophylaxis should continue for minimum 6 weeks, by which time the mother should be linked to appropriate ART services. The duration of daily infant nevirapine prophylaxis will depend on how long the mother was on lifelong ART and whether she is breastfeeding or not. So mothers who are breastfeeding and have a duration of ART of less than 6 months, their babies need an extended nevirapine prophylaxis for 3 months. This is what I have been explaining. 6 weeks should be increased to 12 weeks if ART in the mother was started late in pregnancy, during delivery or postnatally, as adequate period of ART has to be given to achieve optimal viral suppression to make the breast milk safe. There has been a question is, where is Rohini prophylaxis given to baby? If mother is on second line, then Rohini syrup is as prophylaxis. So what are the indications for giving Rohini prophylaxis, or what are the indications where nevirapine is not given? So what are the indications? The infants born to HIV positive mothers, infants born to mothers on second line ART, infants born to mothers who had taken nevirapine prophylaxis in the previous pregnancy need to be, their babies in the next pregnancy need to be given Rohini syrup. Syrup Rohini, if not available, we can give syrup lopinavir, ritonavir boosted lopinavir, but we must reserve this for the babies ART if the baby is detected infected. So avoid using ritonavir boosted lopinavir syrup. Try to get syrup Rohini, and the indications, as I said, HIV-2 infection, mothers on second line, and third is babies born to mothers who have received nevirapine prophylaxis in the previous pregnancy. We must counsel the mother or the parents about DNA PCR testing in the baby for infection. DNA PCR test is done by dried blood spot at 6 weeks, 6 months and 6 weeks after stopping breastfeeding. If one DBS comes positive, another dried blood spot is taken immediately to detect HIV DNA. If 2 tests, consecutive tests are positive, then baby is presumed infected and started on ART. Final testing is done at 18 months, but remember, if the mother is breastfeeding, then final testing will be done after 6 weeks of stopping completely breast milk. What are the infant feeding options available? One is exclusive breastfeeding and replacement feeding. Important thing is to discuss this in the antenatal period. So what is exclusive breastfeeding? Is giving a baby only breast milk and no other liquids or solids, not even water. What is allowed is vitamins and drugs. Otherwise, no water, janambutti, no honey. All this will make it mixed feeding. What is mixed feeding? An infant is referred to be on mixed feeding if he or she is receiving breastfeeding as well as other foods or fluids such as animal or formula milk during first 6 months of life.
Replacement feeding. Mixed feeding. An infant is referred to be on mixed feeding if he or she is receiving breastfeeding as well as other foods or fluids such as animal or formula milk during 6 months of life. Replacement feeding is the process of feeding a baby who is not on breastfeeding with a diet that provides all the nutrients the child needs until the child is fully fed on family food. So, who are the key persons influencing mother's choice? The gynecologists, the PPTCT counselors, pediatricians, feeding counselors, postnatal ward nurses, doctors, patients, family members. All family members need to be counseled because they'll be involved in looking after the pregnant PLHIV. So these are these counseling cards with which we must counsel. This is the same card which is used, what I had initially told, about 100 babies. Of these 100 babies, 65 babies do not get infected, and only 35 babies have a risk of getting infected. What if this is when no intervention is given? So when we give intervention, what is the interventions? That has to be explained to the parents. We start ART in the mother, we do an institutional delivery, we give ARV prophylaxis to the baby, and we practice exclusive breastfeeding during the first 6 months. If we do these interventions, then only 5 babies get infected out of 100. But what we need to explain further to the parents is that if my mother is breastfed, if the mother is on ART and the baby is getting breastfed, then 3 out of 100 babies will get infection through breastfeeding. The rest 97 babies out of the 100 babies will not get HIV infected, will remain healthy and can be breastfed for 12 months. But if I say no, I will not breastfeed my baby, then we give infant formula. What happens? The baby doesn't get HIV, but 85 of the 100 babies will survive and 15 babies will die because of diarrhea or respiratory infections because they have not been given breast milk, which helps in preventing infections in the first year of life. So it's a bargain between losing your child to infections or having a healthy baby with a low risk of HIV. And remember, we are doing an early infant diagnosis. These 3 babies will be immediately started on ART and their life will be saved. So it's very important to counsel and educate mother that exclusive breastfeeding aim, what is the aim? Aim is to make breastfeeding safe. This is done by giving ART in the mother and nevirapine prophylaxis to the baby. Avoid mixed feeding. Exclusive replacement feeding is given if these 6 criteria are met, and it should be given only in those parents who are very resistant to counseling and are very persistent in their answer and say that no, we do not want to give breast milk, or because of some medical conditions mother can't breastfeed. So these are basically a fast made into a simpler thing as safe water and sanitation. Mother has some sufficient infant formula milk. In India, we use animal milk, which can support normal growth and development of the infant. Mother or caregiver can prepare it clean and frequently and store it properly. Mother and or caregiver can in the first 6 months exclusively give infant formula oblique animal milk, and there are no issues of finances or other family issues which will interrupt the continuation of this, then it should be avoided. Mothers or caregivers can access healthcare services. The reason is that these babies, because they're not getting breast milk, will be susceptible to infections. So you'll be visiting, the parents will be visiting hospitals regularly. So you need to have a good hospital nearby. How long do we do continue breastfeeding? So if we are doing early infant diagnosis, as I told you, at 6 weeks, 6 months, and at 18 months also we can do any time we find that the baby becomes symptomatic or you suspect HIV infection in the baby, then we again can do a DBS. If a DBS comes positive, we repeat the DBS. If immediately, so 2 DBS showing HIV DNA detected, the baby started on ART. So if the baby is HIV positive, for these infants, exclusive breastfeeding can be continued up to 2 years. If the baby comes out to be negative at 6 weeks, then repeated at 6 months. We start baby on a complementary feeding after 6 months, and we can continue breastfeeding up to 12 months. And gradually we wean the baby off milk. It's not a sudden weaning, but remember, we should stop breastfeeding only when there is substantial nutritious food is being taken by the baby. That is, the complementary feeding which we start at 6 months needs to be gradually increased so that the baby is taking a well nourished diet, and then the breastfeeding can be weaned. There's a question here which says, Dr. Sunil is saying we should recommend breastfeeding up to 12 months with 3 ARVs to the mother, ARV prophylaxis to infant for 12 weeks. Let me speak again. The ARV prophylaxis extended is only given if the mother's ART duration is less than 6 months at the time of delivery and mother is breastfeeding. If the mother is already on good adherent ART, has the duration more than 6 months by the time the baby is delivered, 6 weeks of ARV prophylaxis is enough to cover the perinatal period. Breast milk is safe because the mother is already taking ART for more than 6 months. So you do not need to cover the breastfeeding period with ARV prophylaxis. So ARV prophylaxis in mothers on ART for more than 6 months needs to be stopped at 6 weeks. Mothers breastfeeding with a ART duration less than 6 months at delivery, babies of such mothers need to extend their ARV prophylaxis up to 3 months. Breastfeeding, see, these are the guidelines which NACO has set. But if you look at the WHO 2016 guidelines, WHO 2016 says that with adherent ART, the babies can continue breastfeeding as babies born to HIV non-infected mothers. This WHO guidelines say that mothers who are on ART and are adherent with their ART, their breast milk is probably nearly as safe as the mothers who are not infected. So whatever guidelines are followed by the mothers who are not infected, where they can feed their babies with breast milk as long as they want, Babies born to adherent mothers who are on lifelong ART can also breastfeed their babies to as long as they want. But the important thing is to continuously follow up these babies for signs of HIV infection, and the last HIV testing has to be done 6 weeks after the breast milk is stopped. What do we do in pregnant women with active TB? All HIV infected pregnant women presenting with cough, fever, night sweats and weight loss should be evaluated for TB, as is the intensified case finding package which has been initiated. ATT should be started first, followed by ART as soon as possible. Even after completion of anti-TB treatment, pregnant women should continue ART, that is because its ART is lifelong ART. For all those HIV TB co-infected who are on a PI based regimen, need to be given rifabutin instead of rifampicin. This is a case study where a 35-year-old PL-HIV pregnant second trimester on ART-TLE for last 2 months on 4 symptom TB screening and follow-up investigations at ART was detected to have sputum positive TB, CB-NAT positive, rifampicin sensitive result. She disclosed that she had been treated for pulmonary TB in the private for 6 months 5 years ago. Repeat CD4 count showed a rise of 65 CD4 cells over baseline CD4 level done 3 months back before ART initiation. So how do we manage this patient? Pulmonary TB in this pregnant woman could be due to iris, as there's a rise of CD4 counts. What we need to do is continue ART. Category 2 ATT has to be started, as she has already taken a course of ATT 5 years ago. Category 2 contains injection streptomycin, which is contraindicated in pregnant women. However, category 2 treatment has to be given without streptomycin for total duration of 8 months. Daily ATT, that is EHRZ for 3 months and HRE for 5 months. CPT, we must remember to give CPT in pregnant women who have CD4s less than 250. The guidelines remain the same, but we forget about starting CPT. CPT prevents what? Opportunistic infections such as pneumocystic pneumonia, toxoplasma, diarrhea, as well as other bacterial infections. And cotrimoxazole should be started if CD4 count as per existing guidelines and continued through pregnancy, delivery and breastfeeding. Ensure that pregnant women take their iron and folic acid regularly. Now, what are the unanswered questions? That is acute HIV during pregnancy or postpartum. How do we diagnose it in resource limited countries? These are the questions which remain unanswered. How to manage infection antenatally and postpartum in acute HIV infection, how to prevent this, and one important thing is repeat HIV testing late in gestation or postpartum. We do a HIV testing when the pregnant lady comes first to the antenatal clinic, but we actually need to do a follow-up testing in the late gestation because maybe she has now become HIV positive. The question is, can we add fluoroquinolones in place of streptomycin? There are no guidelines according to this in the RNTCP, so I will not be able to comment on this, but we can take a expert opinion about whether instead of streptomycin we can add something else. There's no harm in giving fluoroquinolones, but in the guidelines it's not written. So just a summary of PPTCT, free counseling and testing for HIV to all pregnant women as a part of antenatal care, promotion of institutional deliveries, provision of medicines to HIV infected mother and baby to prevent HIV transmission. And over 1 crore pregnant women have been covered annually. 88 lakhs were tested for HIV, 70,700 were found infected, and we've achieved the target of 97.7 initiated on lifelong ART. If you remember the goals which we had set, so we've achieved that goal. And 6,000 babies received nevirapine prophylaxis for 6 weeks. Thank you for listening. But before I stop speaking, I would like to just give you a little tip about the quizzes which we answer during this online course. I would suggest that you do the review cases quiz and self-assessment quizzes before you finally attempt the other quizzes, as that will help you doing the final quiz. These quizzes, which are self-assessment quizzes or optional quizzes, are not time limited and can be repeated again. The final quiz, there's only one attempt, so that should be done the last. Secondly, listen to both the lectures, download the slides, look at the slides. If you are not able to answer some question, wait, there's no time limit for any of the quizzes. They expect you, it's an open book quiz, they expect you to go back to your slides, find out what is the answer. So don't think that it is like a closed book quiz, it's an open book quiz where you can easily refer to whatever the slides are and answer the quizzes. Any questions I'm willing to answer. Okay. The question was that kindly send the link of NACO slides to our email just like last week. All the presentations will be sent to you by today evening so that you can look at the PPTs, revise and then do the quiz. But I would request you to look at the 2 lectures, listen to the 2 lectures in the module, plus look at the reference material, that is the WHO feeding guidelines, the US DHSS guidelines. It will really help you in the quiz. Any other questions? Okay, good afternoon. Thank you for being such a patient listener. I've taken 1.5 hours.